In the conversation we had last week, does anybody have any questions around organizing different joint systems and between the foot and the knee? And did anyone play around with that and have any cool experiences? I'd love to hear about it. Okay, cool. Well, we'll dive a little bit deeper in. Again, to kind of add another layer to this very quickly is when we did the wrist and hand conversation and we were taking the dynamometer, handheld dynamometer, and I was showing you that if you do something like pronate and flex and do an assessment versus flex and then pronate and do an assessment, the output that you're going to see, the net force reaction in this is completely different. Like even just doing it very quickly with myself, right? LBS, if I go full pronation and flex and squeeze as hard as I can, right? 22.8 versus 34.4. We'll do that again differently. Yeah, 21, 24, sorry. So it's this weird that as you start changing positions, even if you get to the exact same position, the order of the configurations that you go through really dramatically changes the output. And you can see this with manual muscle testing, QMAMCs, and you can even see this with dynamometer and crane scales as you start playing around with those things a bit more. Again, I love this because it really gives the client a lot of information. So let's take this and let's start talking about more sensitive organs. And the reason why when we did the assessment with Anna, we were talking about how the brain, the concussion that she may have influenced some of those areas. So we'll do a mouth because that's fun, and we'll do some eyes. Looks like an alien. Good. So well, with absolutely no surprise, from a nervous system perspective, we know that the body is intimately connected. We also know that there are things like central pattern generators, which are movements that our body has inherently learned just through generations and generations of things that are naturally instinctive in our body. And in fact, if you ever see someone take a brand new baby, and I would never do this to any of my kids, but they throw the baby in the water and the baby instantly starts to appear like they're trying to swim, right? Obviously, the child is not conscious of that, but there's something about going into water and feeling the weightlessness and the accommodating resistance of the water that turns into a pattern that looks like swimming. And so swimming and gait cycle and running are all very simple examples of things that our body just instinctively has programs logged in already from generations and generations and generations of evolution. In fact, if any of you have kids, Mike, for me, Matt, with Maxwell, when he was 4 months, he was able to, like I was holding him up and I put his feet on the ground and he would start trying to move one foot in front of the other, which was just like the craziest thing to me. I find that stuff very interesting. But the neat thing about those programs is if we forget about how cool it is that we've got one arm and one leg kind of going back and forth with these central pattern generators, what we are seeing is that regardless of what anatomical muscles we're talking about, there are some really hardwired connections from one side of our body all the way to the other. And so this takes what we've talked about with the link node hub modeling of the nervous system and kind of makes it a bit more practical. Because if we think about something like a walk, where you're walking, you got your left arm back and your right leg back for a part of the gait cycle, well, that means that we have some focus with our eyes looking forward, looking straight ahead. We've got some communication that goes down, incorporates this limb, incorporates some muscles, and then comes down to this leg. So the whole gait cycle walking pattern alone involves a massive chunk of the body, just speaking potentially concentrically or eccentrically, just looking at one of those modes, just looking at the body being in an extended position, because in reality, the entire system is involved. I think this is review and makes sense that we know that we've got these big pieces that are involved. So when we start taking the idea of symmetry, most of us have learned the importance of symmetry through range of motion assessments and functional movement assessments. Like if someone squats or single leg squats or does a range of motion assessment, if we see a difference in motion from one side to the body, from one side to the other, we assume that there's some level of dysfunction. Now, changes in symmetrical motion can happen from a lot of different places. Like very, as you guys know, I'm sure this is review, but to kind of help stack this on, is if someone structurally has a bad knee, right? So they can't go, maybe they've got the normal amount of knee flexion, but they can't extend their knee fully. They have just -5 degrees of knee extension. So an amount that most of us might not notice unless we're actually having someone really extend the knee on the table to see that last bit of extension. Very small amount. But if someone doesn't have that last, for example, that last 5 degree of extension in the knee, which is there mechanically, we have to recognize that any joint motion and movement that we have is absolutely vital for how we articulate motion and absorb force. We've grown, depending on your worldview and body view, our body has evolved and changed many times over to make that how we walk and how we use our knee. Currently, this is the most efficient version that our body's got to deal with the forces of gravity. So if we lose this 5 degrees of extension, and it's technically maybe 1% of the amount of motion, maybe less, compared to the other side, we're not going to notice it. But what's going to start to happen to this central pattern, right? This gait cycle, this thing that we do, right? If you've got a goniometer and you're assessing that you do 10,000 steps a day, that means 5,000 of those steps involves this particular pattern that we're talking about. And with that reduced 5 degrees of extension, what's the body going to start to do over time? What are some of the options that happens when we have this hole in our nervous system and our mechanics? Well, first and foremost, whatever shock absorption and or rigid lever component that comes from the knee that helps us to have a stable base so we can take a step forward or absorb force, that 5 degrees of shock absorption and or propulsion is now gone. So let's stick to the side of shock absorption to make our life easier, right? So you put your foot out in front of you, we call this the flexion side of things. We are missing 5 degrees of shock absorption. So that means that in your shock absorber of your car, the function of the shock is only operating at 99%. That's not that big. It's not a big deal. And that's why these things are insidious and why we need to really try to express how important these things are to our clients, because if they don't take care of them now, they are the things that over time starts to become bigger problems. But mechanically, if we don't have that shock absorption, our body's going to start to figure it out. So if we have that -1% of force of shock absorption, it's going to go either into the same knee joint with less motion to help absorb it. It's going to go more into the skeletal muscle, potentially local, because if the joint can't take some of it or the cartilage can't take it in that position, it'll dump it into the muscular system a bit more. It may dump it into the superior joint system, the proximal joint system, or the distal joint system. And if we have any one, that's just locally, and it could be any one of those things. And I'm sure we've all seen this, right? If someone's missing some motion in their knee, they start getting some discomfort in their knee in a specific spot. Or maybe they don't get discomfort in their knee, but then their foot starts cramping up a lot more on that one side compared to the other. Or they get none of that, and they start getting little sensations in their hip. In any event, we can't compare what's going on here with this decreased motion with what they're feeling, but we do know as mechanists that if there is decreased mechanical motion, it's going to influence how the body works. And if that pattern is there long enough and over again, 5,000 steps a day for many years until this person gets a knee replacement, those skills become anatomically hardwired into the system and they become options for the muscular system. The muscular system and how our body organizes skills starts to recognize that this is the norm and this is how things are going to be. And so, like we talked about last week, if we get that fancy knee replacement in here and the knee buttons everything up and makes the motion perfect, which it doesn't, but say it does, say it makes the motion absolutely perfect, the skill of moving, using different muscles, orchestrating things a little bit differently, however your body's organizing the muscular system to avoid problems there, those patterns don't go away. So when we take this same information, we start thinking about the ocular motor system, the reason why, and I said this last time, and we're going to stack that information on here because I know Chris is excited for it, and I'm excited about it too. The oculomotor system, the TMJ system, all of these facial muscles and many other parts of our body have a very, very high density of sensory motor neurons and neurons in general. The amount of information that goes through these muscles on our face in comparison to muscles like my bicep are completely, I don't say completely different, but it's far more information coming in here. And I believe it's 10 times, but I don't quote me on that for sure. So if we have an organ like our eyes, which in reality, thinking about the mechanics of how our eyes interprets four-dimensional space-time all the time, consistently over and over and over and over again, is crazy how quickly it does that and sees something and organizes your movement around it. But when you get a concussion, you get smacked. I mean, I can't speak to the mechanics of the concussion because I'm certainly outside of my wheelhouse there. But I'll tell you some things that do make sense to me. If someone gets hit on one side, and I mean, again, like we're referencing this off of the lead that we got from Anna's, the information of Anna's mobility profile. I'm not insinuating that this is what happened for Anna by any means, but if someone gets hit at a particular angle, there's a lot of things that could happen that could result in how the concussion happens and the stress on the cervical spine. If the initial blow, if someone gets hit or bumped on the left side of the head, it is possible, depending on how the individual was, that the entire left side cervical spine muscular system could have started to tense up and react. It's also possible that it didn't do anything because the blow was unexpected from a car accident. And as the head gets whipped over, all of these muscles eccentrically catch it. Right? It's just like a really aggressive stretch. As if something hits my head over here and I'm unprepared, what's going to happen is I'm going to get to a certain point over here. And what's going to happen is either these muscles are going to get to that lengthened end of passive insufficiency and yank really, really hard to make sure my head doesn't fall off. Or if the muscles aren't capable of producing that much force, this is where the cervical spine bones get smashed and start to turn into structural damage. So it's funny because when someone gets whiplash, like as much as whiplash sucks, whiplash is actually obviously a fantastic option and layer of redundancy before the bones of the neck get injured. Because if someone gets whiplash, I mean, it's a combination of the muscular stress and what goes on in the brain and all the other organs up here. But if someone gets thrown over and all these muscles catch that really, really quickly, I mean, it starts to make sense why someone's neck is so sore and where someone could get acute or chronic neck problems from an incident like that. Now, with that same idea, right, if we just think about that, right, the throwing over and catching it, that creates an opportunity for the actual brain to actually kind of get shoved into the side wall of the skull and take a bit of stress. And I don't know which side exactly, because again, it would be dependent on how the force was and when it happened. But of course, it could happen initially on the initial blow on the same side skull, or it could come all the way over. And you know, Newton's third law of reaction force, I stop here and the skull is in its little membrane, it's going to keep trying to go to the one to the right side. If someone, I'll be saying this like openly, is if someone gets hit on one side, like I do like to ask if Anna said that she was in a car accident and that's how she got it, or anyone, I'll say that, okay, thank you so much for, when you were in that car accident, do you recall what side you were hit on? I can't make decisions based off of that, but I'm always interested if they're like, if they come in and it's left side traps are sore, right? They got pain here. And they say, oh yeah, I was hit on the left side. There's some interesting stacking of information where I could be interested in exploring, I wonder if this is constantly sore because it eccentrically took a lot of force when there was that accident. Coming back to the brain stuff and then how I translate that to the ocular motor is that if someone's hit on that left side, how the concussion happens in the skull and which side it smacks against in the inside of the skull, the cavity, it could be on both sides. And so it's, perhaps speaking to a concussion specialist to be able to help stack a little bit more information on here, but it could happen on either side. And so if someone tells me they were hit like this, all this does for me is warrant, okay, I'm going to use some of the assessment tools I have biomechanically to see if there's any influence on the rest of the body. Does that make sense? So all I'm trying to show here is that, like, again, when I talk about, I mean, if you guys saw, I did my little 5 pillars of personal training video today where I talk about like a study guide in the Fitness Pro Mentors group. If you want to check it out, it's one of my favorite little things. But, you know, learning more about concussion mechanics and like the small details for me and my clients, I don't have a lot of those. For someone like Chris, he may have more folks like that. And if that's the case, I would say spend a lot more time studying that way. What does make sense for me from a force perspective is I do know if someone is hit in a particular direction, that there is some opportunity for reaction force on either side of that system, concussion, impact at the shoulder, whatever it may be. So when someone has something like this, I instantly start to wonder, okay, how is this influencing the rest of the body? And so again, because this is not a muscle system specialist program, I mean, I'm not going to I can't teach Greg Mack stuff in these study groups. But what I can do is talk about the thought process I have around it and how I like to use it. Because if we think about this same region, many of the muscles that interdigitate to O1, C1, C1, C2 connect to some of the organs like the muscles that help to articulate the mouth, the muscles that help to move things around the nose and our eyes, and even the ocular motor muscles. They all go to a very similar nerve pathway and information center. And so when I get an impact like this, I do want to know, is this going to influence how the rest of the body is moving in any way? Because if I come back to that same thing here with this central pattern, or what I was regarding last week with the person with the one eye, if someone has some stress and some light sensitivity from the concussion on one eye, if they have light sensitivity, I have a light to the left side of my here that's illuminating my face. I have light sensitivity in this eye. I would be doing everything I could to slightly move my head away to not get as much light in my eye. And if I'm doing that enough times throughout the day while I'm walking, it's going to start changing how I walk. Does that make sense? Right, so this is the idea last week where I brought up, if someone's blind in one eye, right, and this is a review again, obviously they're going to look differently to try and get their eye closer to the foreground, where they're going, so they can interpret the physics better. If someone was just partially blind, right, if it's not perfect vision, they're just going to turn their head slightly. So without a doubt, everything in the ocular motor system could influence how the body moves. Now let's use a little bit more abstract one that you can learn certainly more about in Kapanji's manuals on the upper extremity. Let's talk about the jaw, right? Because the conversation about jaw muscles lines straight up with the exact same thought process around the ocular motor system. Chris, why are you smiling? What's wrong with the jaw?
Nothing, man. Nothing at all. I'm excited because I'm one of these TMJ sufferers and a concussion sufferer. So,
yeah, okay.
Wheelhouse.
Selfish. I'm just kidding. I got it. Okay, so it's the same idea with that jaw. With the jaw, is that even though we think about the jaw being a nom thing and a talking thing, it does help us with motion of our head, and a lot of the muscles do help with cervical motion. If you ever, this is a weird one, and I was taught this by a mentor of mine, so this is not a story of mine, but if you ever watch those slow motion captions of someone running, right? If you're watching someone doing sprinting, they never have their teeth ground shut, right? They're running, and if you watch where they sway, their jaw sways, and I'm exaggerating a lot, of course, but their jaw moves to one side, like kind of goes from one side to the other a little bit as they run. You can almost see it. And it's the same idea if you ever watch one of those cartoons and they get punched, right? The Bugs Bunny cartoon, right? They get hit in the temple and the jaw kind of floats the other direction underneath the hand, right? So this jaw system, I used to say was a 4-bar linkage system because it does have where the TMJ attaches to the mastoid process. Mastoid process, that's probably not correct, but there are 2 little connections on both sides that creates kind of predictable and consistent motion. So if I push on this side, there's obviously going to be some predictable motion on this side of my jaw. And to help kind of stack this, I've said this before, but like if you think of the muscle platysma, which is that huge muscle that goes from the base of the jaw down to the top of the clavicle and interdigitates with pecs and all that stuff, right? If you try to look up as high as you can while keeping your jaw shut versus opening your mouth, you can look up a heck of a lot high, right? It's weird, isn't it, Chris? Like it feels weird, right? And so there's an amount of jaw motion that is absolutely required for cervical spine motion. Same thing. Like if you try to turn your head all the way, it's not as much, but you keep your teeth shut and then you open your jaw, you're able to turn your head just a little bit more. And this is where, if you ever you're watching someone drive and they're checking their blind spot, what do people do? Right? Their mouth, their mouth is open when they look over their shoulder. I'm exaggerating, but watch these things. And it's not like the jaw is not this massive pillar. But what I am trying to suggest is that if stress happens at the jaw, if someone's had a major dental surgery, if someone's been, concussion from a fight, been punched or knocked, or someone's had surgery at the one of the articulations of the jaw, this stuff all plays a role. So I'm interested, if someone's had a concussion, the eyes and the mouth, how these things may influence the rest of the system. Because if you think about that sprinter, right, and they move their head to one side when they run and their jaw goes the other way and it kind of sways back and forth. Again, this is going back to some old reading I did, but there was an author that suggested that the jaw kind of like, oh gosh, I forget the name of it. But when you see people on balance rods and they're holding those long, long sticks and the balance rod kind of hangs a little lower than the rope they're balancing on to help lower the center of gravity to help with balance. Well, he was suggesting the jaw doesn't do that, but it does try to help create more balance at the skull. So when you move your head to one side, the jaw kind of goes to the other side to keep it centered and then coming back, similar to the centrifugation conversation that Taylor said. I don't have any data on that, so I can't source that well, just more of a food for thought kind of thing. So if we think about that sprinter though, and the jaw's going from one side to the other, and you have someone who's a sprinter or a runner, and their jaw's not moving those 5 degrees to the one side, but the body's trying to do it to help with shock absorption and management of the neck, what's the body going to do to make up that 5 degrees of motion? It's going to move things differently. And this is where someone gets hit in the head, someone's had a big surgery on their teeth, someone has a glass eye, like anything that involves neck up stuff, for me, it warrants more assessments from a mechanical perspective. So this is where I'm a fan of the ocular motor assessment that Greg Mack teaches. I think it's pretty clever. This is where the TMJ assessment stuff that is taught both in muscle activation techniques, clinical kinesiology, and MSS stuff is pretty cool. This is where cervical spine influence stuff. Right? Checking the implications of cervical positions, I think, is really, really cool. And then not only cervical, right? Cervical influence screening, but cervical versus capital. And I don't want to try to complicate this, but this is where the nitty-gritty biomechanics conversations we have about on Wednesdays and today on Fridays for like a data recognition process, data assimilation, it goes a long way because each one of these small things do stack up. So if we were going to create a preliminary thought process to try and assess these things, there's a couple easy things. First and foremost, using your knowledge. Before I get into this, actually, does anyone have any quick questions? Cool. Okay. Right. So
Brandon, I got a question.
Yes, sir.
Can you just give it a quick example of the capital kind of assessment? Is that just tilt the head back?
Yes. Tell you what, give me 3 minutes and I will do that. Cool. That's a great question. Right. So if we're coming up with a thought process of these things, this is where I would say, first and foremost, besides getting into influence testing like we were doing last week, just talking about range of motion, here's a great place to start. And this leads into Ryan's question here. And stacking information from last week. So first and foremost, I would say explore doing range of motion assessments on each of these pieces. And of course, most of them are going to be active range of motion assessments. So we're trying to make it, we can't really do passive neck range of motion assessments well. You can do some, but they start to get risky and you start sticking your fingers into people's necks. So I'm not a huge fan of some of those kind of like OA, AA assessments that some of us may have been taught at different points in our career personally. Now, as far as range of motion goes, it's fairly simple. From the eye, jaw, and gross cervical end, right? Easily, you could do it seated, you could do it laying, but you could easily have someone, and this is where, I don't know if you guys have seen this, there's a certification that I took a long time ago that talked about doing this kind of stuff, following a pen, right? You could easily have someone looking at a tip of a pen and ask them, hey, don't turn your head, but let me know when you can't see the tip of the pen anymore. So you kind of hold it in front of them, you look straight, they look straight at the tip of the pen, they don't turn their head, and they go all the way, and as soon as they can't see it anymore, they'll go stop, and then you kind of just make note of how far each one goes. So that way you can start to do like a very basic ocular motor range of motion assessment, just to see if there's any differences. And openly, if you've had someone that's had a concussion, and Chris, you may experience this, you might find that when you look to the left and up or something like that, that you might get dizzy. Or you might not. But it's interesting to see, and this is where getting more data is important, because before we do ocular motor assessments for someone who's more sensitive, I'll do this first because I want to make sure that they're okay. So very quickly, I'm a concussion person. I had a concussion. I played hockey, and I was a bit of a pusher, and I might have got into a couple scraps, and I might have got knocked out one time. No big deal. It's fine. And I got hit real bad. And when I got hit, left side of my head took me out. And so for me, when I do this, and I've worked on this, if I go over to the right side, I got a lot of range of motion over here. If I come over to the left, I actually can't go as far easily without getting weird sensation on the left side of my eyes. So you might get some subjective info there. Mr. Chris.
I was just gonna say, as you're doing this, I'm like trying it, and I'm like, you know what? Yeah, any kind of like, if I gotta stay level, left and right is cool, but any of them when you combine right and up or left and up, yeah, sounds so much fun.
Yeah. So, and again, that doesn't mean anything except that it's different, right?
Yeah.
And so this is where do those range of motion assessments and make that data, collect that data. And for me, if I look over to the left, I start to get strain over here. It gets tight over here. Again, exercise personal trainer. We can't interpret this information except that it is different on the left side to the right side. And it's possible, because what I care more about is that it is unlikely that anyone here has had a concussion. You are not correcting the concussion, in my opinion, with what we're doing. But what we are doing is with that central pattern generating stuff and the skills that we do, we're trying to identify, right, the shotgun spray of influence. So if you know it feels weird over here, I want to know if it feels weird over here, if someone's going to lose the ability to control other parts of their body when they look over there, which may not be prudent for symmetrical exercises like squats and bench press and machine presses and machine rows. But if someone's doing something like a transverse plane exercise and they're doing rotary torso, well, things might start to get weird fast. Because when people turn to the left, well, if I turn to the left, I go to the left. I mean, if my eyes go to the left. Does that make sense? So I want to make sure that I'm being clear that we're staying in our lane here. All we're doing is taking information of things that are medical and trying to see, does it influence our exercise decision-making process? Just before I go deeper down this, I want to make sure everyone knows that I'm respecting our lane. It's just important to talk more about this. So, right. So first and foremost, look, this is not taught in any of the courses that you've taken. It's just looking to the left, looking to the right. Hey, did you notice the difference? Client, and then Chris was watching Michelle do it, and did she go less far to the left than the right, and make a note about it. Same thing, just looking straight up, looking straight down, and then if you want to get creative, right, instead of going north, east, west, and south, you can start going northeast, northwest, and all that kind of stuff. It's up to you. I would just stay really basic to start. TMJ stuff, TMJ range of motion assessments are fairly simple. I would see, one thing that you can do if you want to get comfortable with someone, you can put your hands just where the TMJ is and just have them when they clench their teeth. Do you feel anything different there? So if you find the cheekbones and you go below it where the cheek muscles are and they tense, right? For most of us, you probably won't feel any different on yourself, but if you're doing both sides, right, you might be able to feel that one goes boop, boop, or something like that, or one doesn't move and the other one does move. Interesting piece of information. You won't be able to see that one visually too much. Another easy one without getting your hands on them is just opening the jaw. And when they open the jaw, what you want to see is, do they go, right? Do they open and sway to one side? Because if someone's got a big problem or a small problem, yeah, exactly. Thanks, Chris. You ready for hot dogs? I like it, right? Open up and you sway to one side, come down and sway to the other side, right? You want to see that because that'll potentially tell you, okay, Is it getting locked up on one side? Is there some information that we can collect on the other side? Now, on that note, this is where the next part comes in. If someone opened their jaw and it sways down to my left, now what we could do is have them have like a slack jaw and just have them slide their jaw to the left side. Right? And just see, again, is there any difference there? Why are we doing this again? Well, there's a lot of muscles that attach to this thing, and it is possible that these things could influence range of motion. So these jaw things I'm showing you now actually double back to Ryan's question about the cervical capital stuff. So taking what we talked about last week with the foot and the knee, the same concepts apply within the cervical spine and the capital spine. So again, capital spine, what we're talking about really is the occiput attaching to C1, and then the cervical spine is C1 to C7. So my personal preference is to make these motion assessments for my clients as simple as possible to get some tacit layer information, and then I get more sophisticated as I need more info if I'm confused about something. And I don't mean get sophisticated like make it harder, but try to collect more stuff. So like very simply, just going through all three planes. Transverse plane, sagittal plane, frontal plane, good. Now from there, without adding anything without being too specific, we can do all the same things from a flexed position and an extended position. So when they're extended, right, obviously if they're extended, they can't go into more extension. When they're extended, we could do transverse, frontal. When they're flexed, transverse, frontal. Let's see if there's any influence there. These are all very gross motion assessments and probably familiar to you. Now, what we can start doing now is start being more specific with the capital influence. So we can take the skull and go, and it's hard to do. I hope this translates on camera well. Right? Capital motion, technically you've got a little bit of capital motion in every plane, but in reality, the only real motion you're going to be able to have some volitional contractile control over is going to be the capital extension and flexion. Right? So what you could do, Ryan, for that is pick an order and try to see, is there an influence? Now, I'm not going to go through all of these because there would be probably 60 or so, right? But say we just stick in the sagittal plane, right? Taking the same example here, boom, 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 boom. Do I want to squish my chin? So capital flexion, cervical flexion, capital extension, cervical flexion. Cervical flexion, capital flexion, cervical flexion, capital extension. Does that make sense? Right? So even right there, just going forward into the sagittal plane, there are 4 options. Well, there's actually 5 options, right? The 5th option is just going for it. And then the other options are neck up, neck down, chin in, down, chin up, down. And each one of those gives you more information. Now, 100% open, I do not do this with every person, and I do not do this with every neck client. I would ask you to think about knowing these options as like the mechanical options as a deeper pool of information that you can collect if you need that information or you want that information. Because if you have someone, if you got like, Chris seems like a pretty strong and healthy guy, but he's had some concussions and stuff like that. Same with Anna and same with myself. We're all pretty healthy, we're exercises and we take care of our body. It is possible that by doing, right, that's just 4 options forward. If I do those 5 options forward, those 5 options backward, and then I do an additional 5 for to the left and to the right and then side and side, that is a lot of very, very tiny neck motions that most people don't do. And openly for most of us would already be an exceeded cervical workout for everyone in this room, let alone the people that were probably doing it who actually need those assessments who are pretty sensitive. So I'm not going to run through every single one of those examples, but that's kind of the idea. It's that, right, just very quickly, cervical rotation to the left, capital flexion, rotation to the left, capital extension, rotation to the left, rotate to the left, capital flexion, extension, rotation to the left, capital flexion, right? And so there are so many more pieces of information that you'll see. Now, this will help to set up the eye and jaw influence testing. What I find that works pretty well is whichever one that you do first seems to be more of the captain of the ship if you can do some testing on it. So if someone's lower quality strength with the scenario, or you see a decrease in range of motion, like for example, one thing that I have seen is someone does rotation, right? If I do capital flexion and rotation versus capital flexion then rotation versus rotation and capital flexion, right? There's a huge difference between those two on me versus this side, right? You see there's a big difference there for me. It's capital flexion. So it changes a lot for me. And so I find that for me and for most clients, what I like to try and do is if I see capital flexion and rotation is so different, but their actual rotation is fine, that tells me that the rotation is not a problem. Like the rotation's good. Cervical spine, transverse plane, it's pretty symmetrical. It's when we add the influence of the capital flexion that Brandon loses rotation to the left versus the right. Does that make sense? So it's why I like to check all the gross stuff, the big stuff, like with Anna as a perfect example, which didn't really play out too far. It did a little, actually. We did transverse plane motion, and I just got some info with how she's moving with her trunk. And then we did shoulder blades. And then we did shoulder blades to see how it was different from one side to the other. I full well know that when I fully retract, we're going into some thoracic spine extension, and we're going to see a decrease in range of motion because she's locking out her facets a little bit. But I'm not worried about that. I'm worried about, is there a difference from the left to the right? Because if she does this, totally, that's a different scenario. We have evidence that she should be limited, but not asymmetrically limited. And so this is where, range of motion assessment sheets are tough if you're following a linear order, because you can start with a group, like a gross motion page, but then there's a lot of like digging and deeping you got to go by organizing things. And we're just talking about local segments right now. So I know this is a long-winded way to get to the ocular motor stuff, but I need the concepts to make sense, because the concept of the ocular motor and TMJ stuff goes so much more beyond the just eyes and jaw, that these concepts could be applied to nerve damaged areas. It could be applied to joint systems like the knee I was saying, where the knee replacement was and all that. These concepts extend to that same world. So range of motion, that's a no-brainer. Now, after no range of motion, what I like to try and do, before I get too specific, is I like to try and use my hands to do some sort of force tolerance testing. Right? So I like to push on them to see, can they sustain a position from one side to the other, especially with these asymmetrical ranges. So this is where I'll do the QMAMCs, pushing on somebody to try and see, is there a difference in strength from one side? Oh, it's not going to work. From one side to the other. And I'll make a list of the differences. So if I see limitations in left rotation and extension, I'll push on those on the left and right side to see if there's any differences. And then I'll make a list of what's low quality and what's low quality. Now, at this point, if there's enough stability in that area where I'm not worried about making people do crazy eye and jaw stuff, this is where I like to use the cervical influence screening and the TMJ screening style stuff that was talked about in MAT, muscle activation techniques, but taking the concepts and extrapolating them a little bit. Now, in the manual muscle testing course, the muscle system specialist course, Greg Mack will talk about using muscles that have similar innervation. So if you're looking at ocular motor muscles, doing something like a shrugged position to stimulate the upper trap, that makes a lot of sense to me, but I will leave him to go over those particular pieces, but the concept's there. Most of the time, like I did with Anna, because I find that for most folks, doing a test like this and shrugging their shoulder blade up with eye stuff, most of my clients, I find that to be pretty sensitive, especially the people who need those assessments. So what I'll try to do is, if I am seeing something like Chris said, weird with the ocular motor system, is I'll make a list of the ranges I want to check. So easily, we'll just say north, west, east, south, just to make life easy. Then have them look to that position and pick a relatively neutral position, like hip abduction or GH shoulder extension just from neutral. Just to start. And I might not do both, or I might. Depends on the individual. So easily what you can have them do is you do a test on the shoulder, make sure it's stable. And then attached one of these ranges. What are you seeing, Chris? Are you playing with your eyes and doing stuff?
Yeah, man. Yes, and it's weird.
Yeah.
So, okay.
What are you experiencing? Tell me before we go further.
Doing this eye thing. We just said, me looking head straight, looking up does not feel good in my brain world. So I do my left rotation. Wow, look at me. I can look at all the junk on my shelf back there. I look up and do it. I'm nowhere near there.
Yeah. Okay, so here let's play a game here. Let's
Now
go
what do I
with
do?
this, right? Exactly. Well, we're gonna you and I are gonna try something right now because I want to see. Okay, so let's try and see this first. So do the exact same thing to the right.
So no eye kind of thing, just looking. Cool. Okay. Eyes up. Yeah, it's still pretty cool. I can still see my tree. My
Okay,
little
so
plant.
look up again and go to the left. Look up and go to the left. Let's just see if we can see a difference.
Oh, look at that.
Okay. Yeah. Okay. Right. So here's a perfect example. So we're going to try and do something with Chris. Now, of course, we can't do any hands-on testing with him to get any idea of force tolerance, but we can see that the aggregate range of motion difference is there. Now, I'll be open with 10 minutes left in the session and doing this through Zoom in a group setting and improvising. I have no idea if this is going to work, but I will tell you this is exactly the thought process I would go through and exactly what I would tell Chris to do if he was a client of mine and we were trying to do something over Zoom for this problem. And full well saying that, Chris, I've got insurance, but this is a test, and anything you do on recording is at your own volition, and I'm merely just going to guide you, and if you choose to do something and something doesn't go right and your shelf falls on you, I blame Taylor. Okay, so just keep in mind here that when we're watching Chris do this, right, he turns to the left, his trunk rotation from neutral seated position is fine. When he looks up and goes to the left, looks up, the eye influence to the left is the problem. It seems like, I shouldn't say the problem, but it's influencing the motion. So Chris, try this. Sit up tall, okay? Think of this. We're going to do this little exercise set. Don't do anything with your eyes yet, okay? Turn all the way to the left with your torso and get to that end range where you're feeling some tension in your midsection and things get a little tight, okay? Keep pushing into the end range a little bit so you get a little asymmetric contraction. Now, look up while you're there and keep looking up for 3, 2, 1. Relax all that and come back, okay? Relax, relax, relax. Tall again. You're not done. Turn over to the left as far as you can. Don't do it with your eyes. Turn all the way over to the left. Go all the way till you feel some isometric tension. It's getting a little tight, and then look up a little. Look up, look up, look up. Good. Come back. We're going to do that one more time. Okay? Same thing. When you get over there, I want you to try and stretch a little bit. So get all the way over and try and turn, and you feel those co-contractions happen. So turn all the way over. Get really, really tight in the midsection so everything kind of firms up, and then look up. Keep looking up. 3, 2, 1. And rest. Okay, come back. So what am I trying to do? We have information that his trunk rotation, that felt weird, eh?
Yeah, brain stuff.
Yeah.
It's good.
Yeah.
We keep going. It's
Right.
like,
So what I'm trying to do is we know his trunk rotation is good. We know that the looking up is influencing his motion to the left side. So what I'm trying to do is I'm trying to reverse it. So we're trying to go into the trunk rotated position and then call on that weird ocular motor skill to see if we can use that Hebbian learning model. And like I said, I can't remember where I said this, but hot dog it, right? Get him over into a position and then take another bite and add something else to see if it makes a difference. If it doesn't make a difference, we'll try something a little different. So Chris, come back, look up, and then look and try and turn to the left. Cool, right?
Oh.
Come back. So it looked like a little bit more motion, but not a lot. How'd it feel for you?
It felt like based on peripherals of what I was using, I did go further.
Cool. Now,
I didn't have that jam at the end.
awesome. So let's try and make this a little bit more specific now. So how close are you to your background?
Yeah, yeah, I'm not gonna reach. Don't
No,
worry.
no, I want you to
Shells
touch
ain't
it. So
falling.
what I want you to do, so I'll be open very quickly with what I just did with Chris, just kind of speaking candidly, that little isometric twist in thing. I do that in demo presentations I do because people can feel some things. Chris, I don't want you to do the co-contraction thing. What I want you to do is you're going to put your arms out in front of you. I want you to rotate all the way until the
Yeah.
outside of your arm hits the machine, hits the wall. So you're going to do an isometric. When you get over there, as you can imagine, I want you to push into it, do an isometric first. After you're doing the isometric, I want you to look up and keep looking up and really look up. Try to get to the end range of motion.
All right.
So I'm not a big fan of
Let's
co-contraction.
find-
Yeah. Let's try and make this work for us here, Chris. Work, man. Dance.
Try here.
If that shelf
Watch.
falls on you, I'm gonna have a bad day.
Yeah, I'm gonna have a bad day too, man.
Okay, so
All right, so
turn
I
all the
got
way
my
over.
coke.
So no co-contraction. You're pushing into the wall, right? And then from there, look up and keep trying to stretch your eyes, looking up, and then rest and do it again for 3 seconds, 2 more times. We can't see Chris, but we'll trust that he's doing it. Not drinking beer.
And
Good. Keep looking up. Right. So what we're getting Chris to do is do the rotation isometric into the wall. So that way it's all around the agonist resistance fighters, so to speak, that turn him to the left. Good, Chris. Let me know when you're done the 3 and then come back. And then having him look up second to really access that end range of the ocular motor motion. So we already saw the range of motion increase. Let's see if it makes any difference.
yo, man, I'm breaking a sweat over here, man.
Good. That'll be $150. All right.
No
So,
problem.
okay. So look
So,
up. Look up and then rotate to the left. Cool. And then look up and look to the right. Sorry, look up and turn to the right. Cool. So it's not quite 100% perfect yet, but you can see where we're going with this. And this is exactly like if Chris were here right now, you want to talk about where this turns into a personal training session. Well, first and foremost, he's like, well, I'm breaking a sweat. So we're already exercising. But the easiest thing you could do is have them like take a trunk rotation exercise, do a cable rotation, get to the end range of motion and then look to the left. Or if you've got, I know Ryan and a few of you got isofits or something you can push into, right? Do a trunk rotation thing and then have them look to the left, right? This is where what we just did is not a fixing intervention strategy. It's a workout. But it's mixing the orders up and figuring it out. Because how crazy is it? Like this is where mixing the order really goes a long way. So Chris, let's try one more thing. Let's just have a little fun and then we'll round out today. And then I'll talk more about this a little bit next week. But this is a much more simple one. And Chris, at your conditioning may not work, but I got a 78-year-old woman I'm doing this with Zoom with right now. So we're not going to do, you're not going to do any pushing into anything. All I want you to do is we're going to kind of make it a bit more dynamic. And so you're going to keep looking straight ahead. You're going to rotate all the way to the left. When you get to the end of the left, you can't turn any further. Here, Chris, 1 second, stay with me here. When you get to the end of the left, you can't go any further. You're going to get to the end, look over to the left really, really hard, relax your eyes and come back. So it'll look just like this. Right? Does that make sense? So you're kind of not doing anything with your eyes. You turn your torso and then you really stretch at the end for 1 Mississippi and then come back.
All right.
So we're going to try and just do big turn. Good. Right? So what's happening here? Come back. Just for 1 Mississippi, Chris. Just a small.
Okay.
Yeah, keep going. Keep going. Right? So we're accessing the trunk rotation without the eye influence. It's not limited by it. And at the end, we're just calling on it just for a second. Good. Do 2 more like that. So he's really only doing 5 Mississippis of ocular motor looking to the left, which is sensitive, while doing something he's good at, which is trunk rotating. 1 more. Good. And then relax. Feel okay?
Up is the sensitive one.
Yeah, we're coming there next. Now come back.
Okay.
Now we're going to do the same thing and you're going to look up. So you're going to go, you're going to look up and then come back.
Go.
Look up,
Go.
drive up. Good. But really look up there. Like try to look, watch your hair grow.
Go. Oh, yeah, that's never going to happen.
Yeah, I'm in the same boat. Don't worry. I'll be there soon.
Yeah, you will be.
Okay. Do 1 more and then we'll just check this and I want to make sure what we're doing it makes sense for everybody. Good.
Okay.
So I would call this personal training, right? Like this is personal training on a function end, right? Chris isn't going to grow any brand new, amazing, cool looking muscles with this. But if he comes in for, exercising pain-free and function, this is a really, really cool, really cool progression. And this turns into getting someone on the Med-X torso rotation or the Cybex torso rotation. So Chris, look up and then turn to the left. Let's just see.
Oh my God, it's fucking magic.
Yeah.
Whatever.
Right. But this is so it's cool. So that was a perfect example of that, but it's all we're doing, right? Like that's where it's not magic, but why it's important to recognize the influence of it is that we got to stay we got to make sure we don't try to go into concussion land, but knowing that there's a difference in your eyes or how it influences your mouth or any other sensitive organs here and how it influences motion asymmetrically is what's important. And so very candidly, I will tell anybody who tries to do what I just did with Chris, when I talk to a client about this, I never set it up such like, this is gonna work. Wait till you see this magic sauce, right? It's always like, hey, can we try an experiment? I wanna see if we can make a change here. And if not, that's totally fine, right? Because what ends up happening is you're not committing to any sort of panacea. And then when you do it, right, Chris knows what I'm gonna do. And he's like, this is magic, right? This is what you wanna have. Because if a client has that experience, from a sales perspective, that's an awesome passive sales strategy, but also now okay, trunk rotation first, ocular motor second. If I can progress that along my exercise equation, resistance, motion, all that stuff, now that's how you're going to have this thing stay forever. That was sick. Thank you, Chris.
That was cool. Thanks, buddy.
Yeah, no, my pleasure. So I hope that was cool, actually. Does anyone have any questions or anything I can kind of shed some more light on as to what just happened with Chris? I think that's the most powerful example we could have done because I do like using my hands as a skill set, but the question I have people ask all the time is, well, did we just potentiate the skill set, right? Did you potentiate it by using your hands, right? Obviously I couldn't touch Chris, so everything that happened with Chris works. And so if you're not someone who wants to do manual muscle testing, you just want to do exercises, as you can see, just using range of motion and being really creative with it, and then doing potentiation exercises in the right order can go a really long way. So that was awesome. And then anyone who's doing, I was talking to Ryan, I was talking to Brad Thorpe about this. I mean, this is the fun stuff with, isometric machines, but really, using them for super specific things. Like I love this and I'm excited about this. So cool. Before we button up today, does anyone have any questions? Awesome. So, next week, I think we'll carry off of this and we'll expand on the configurationalism idea a bit more and maybe stack a few more things on here. But honestly, I would say that Chris's practical example, though, just kind of nailed everything for us. So that was awesome. So cool. All right, everyone. Thanks so much. That was sick.
Hey, thanks, Brandon. Now I know what I'm doing.
My pleasure. That's right. Happy COVID April 16th.